Welcome to my channel. In this video, I will talk about adenocarcinoma of the lung. Adenocarcinoma of the lung typically arises in the peripheral regions of the lung parenchyma. Adenocarcinoma is the most common form of lung cancer overall in the general population, especially among women and non-smokers. Although adenocarcinoma has the weakest association with smoking, it can still occur in smokers. So if the vignette describes the patient as non-smoker, do not rule out the diagnosis. The most common activating somatic driver mutations involved in the carcinogenesis of adenocarcinoma include KRAS, EGFR, and ALK genes. Patients with adenocarcinoma containing these mutations are highly responsive to targeted therapy with tyrosine kinase inhibitors. For example, osimertinib is used for EGFR mutations, alectinib for ALK rearrangements, and sotorasib for KRAS mutations. The histopathology of invasive adenocarcinoma is characterized by cuboidal to low columnar, hyperchromatic cells exhibiting glandular differentiation, manifested as gland formation or intracytoplasmic mucin production. As a result, these tumor cells typically stain positive for mucin. Lung adenocarcinoma is thought to develop in a stepwise progression. It begins with a precancerous lesion known as atypical adenomatous hyperplasia that further progressed to adenocarcinoma in situ and invasive adenocarcinoma. Atypical adenomatous hyperplasia AH is a small area of 5 mm characterized by dysplastic pneumocytes lining alveolar walls. As more genetic mutations accumulate, AAH can progress to adenocarcinoma in situ, AIS. Adenocarcinoma in situ, previously known as bronchioloalveolar carcinoma, is a subtype of lung adenocarcinoma that originates from Clara cells or type 2 pneumocytes. It is a larger lesion, up to 3 cm in diameter, and is composed entirely of dysplastic columnar cells that show more pronounced cytologic atypia than seen in AAH. These mucus-containing atypical columnar cells proliferate along pre-existing alveolar septa without crossing the basement membrane. This pattern of growth is termed lipidic growth. The result is thickened alveolar walls that on imaging appear as hazy, pneumonia-like infiltrates. Patients with adenocarcinoma in situ typically present with dyspnea, cough with large amount of a golden brown sputum. Adenocarcinoma in situ has a better prognosis. Once the lesion enlarges beyond 3 cm and invades through the basement membrane, it is classified as invasive adenocarcinoma, with the full ability to infiltrate adjacent tissues and metastasize. Adenocarcinoma typically presents with cough, dyspnea, weight loss, hemoptysis, and pleural effusion. Adenocarcinoma also presents with symptoms of paraneoplastic syndromes. There are 3 paraneoplastic syndromes associated with adenocarcinoma of the lung: dermatomyositis or polymyositis, migratory thrombophlebitis, Trousseau syndrome, and hypertrophic osteoarthropathy. Now let's talk about hypertrophic osteoarthropathy. Hypertrophic osteoarthropathy, HOA, is a paraneoplastic syndrome associated with adenocarcinoma of the lung. In HOA, there is abnormal proliferation of the skin and osseous tissue at the distal parts of the extremities. It is characterized by the triad of fingernail clubbing, painful long bones, and symmetric bilateral painful arthropathy. The painful arthropathy is due to joint enlargement and synovial effusions, for example, in the wrist joints. The pain in long bones is due to periostosis, which is an inflammatory thickening of the periosteum. This periosteal reaction can be seen on imaging as an increased uptake on bone scan or PET. Digital clubbing is thickening and widening of the nail bed and digital phalanges, giving the fingers a bulbous broomstick appearance. This enlarged fingertip and increased curvature nail plate is due to connective tissue proliferation at the nail bed and distal phalanx. Clinically, clubbing is assessed by measuring the Lovibond angle, the angle between the nail plate and the proximal nail fold on lateral view. Normally, this angle is around 160 degrees. Clubbing is diagnosed when it exceeds 180 degrees. Additionally, the normal diamond-shaped window, Shamroth's sign, between the dorsal surfaces of the terminal phalanges is lost. Digital clubbing is associated with bronchogenic carcinoma, especially adenocarcinoma, metastasis to the lung, mesothelioma, lung abscess, bronchiectasis, including cystic fibrosis, cyanotic congenital heart disease, and interstitial lung disease. Importantly, chronic obstructive pulmonary disease, COPD, is typically not associated with clubbing. Therefore, the presence of clubbing in a patient with COPD should prompt evaluation for occult malignancy, starting with a chest radiograph. Clubbing can occur by itself or associated with hypertrophic osteoarthropathy, and both could be different manifestations of the same disease process. So what is the pathogenesis of hypertrophic osteoarthropathy? It is unclear, but there are two proposed mechanisms, both involving growth factors. One mechanism is that tumor-derived growth factors, such as vascular endothelial growth factor, VF, stimulate growth. The second proposed mechanism is related to megakaryocytes. Under normal conditions, megakaryocytes are fragmented in the pulmonary circulation. However, when the pulmonary circulation is disrupted by tumors or chronic lung inflammation, the megakaryocytes skip or bypass the normal fragmentation and enter systemic circulation. Due to their large size, they become entrapped in the capillaries of the distal extremities, where they release platelet-derived growth factor, PDGF, and VGF. The cumulative effect of these mechanisms is the activation of hypoxic inflammatory pathways, with subsequent release of platelet-derived and fibroblast-derived growth factors such as PDGF, VGF, and TGFB. This growth factors promote local fibrovascular in the fingertips through periosteal new bone and connective tissue formation by activated fibroblasts, angiogenesis, and edema via increased capillary permeability, ultimately leading to clubbing and periostosis. Thank you for watching this clinical overview. If you found the video helpful, please like, share, and subscribe, and don't forget to leave your comments below. Until next time, happy studying and good luck.